Se encuentran afuera del auditorio para que nos acompañen.
Those outside the auditorium, please proceed inside.
Eso. Ahí está perfecto. Bueno, vamos a dar inicio a las personas que están
Let's
conectadas.
resume.
También
Those
van a
of
ser
you
parte
online will
de
also be
esta
part
invitación
of
que nos va
this
a
invitation
hacer en este momento
that
la doctora María
Dr. María
Alejandra
Alejandra Pérez
Pérez
from
de AstraZeneca. Doctora,
AstraZeneca.
bienvenida a la Universidad Javeriana,
Doctor,
su
welcome
casa.
to Javeriana University.
Buenos días a todos, doctora.
Good
Muchísimas
morning to
gracias
everyone,
por
Doctor.
la
Thank
presentación y
you
un
very
gusto
much for the
saludarlos.
presentation. I'm
Primero
delighted
quiero
to be here.
felicitar,
I'd
por
like to
supuesto, a la universidad, a
congratulate
NPI, a todos los
NPI, the
colaboradores y también
university, and everyone
patrocinadores por
involved,
este
all the
congreso.
sponsors
Realmente es
for this
necesario.
Congress. It is
Yo aquí no soy la
necessary.
experta como todos
I
ustedes,
am not an
pero sí
expert
soy
as
conocedora
you are,
de
but I
todo el
know
trabajo que todavía se tiene que
all the
hacer
work
por
that
los pacientes, por la
remains
navegación
to
de
be
pacientes,
done
las
for the
pacientes, por ejemplo, con
patients
cáncer de
for
mama, a
breast
pesar de que han
cancer
habido
patients,
muchísimos
despite
esfuerzos
we've
a través de los años y en todos los países se han tenido
committed a
unos grandes
lot throughout the
avances
years, and we've moved
en
forward.
estas métricas, en estos
Some advances
indicadores
in these metrics
de
and
los
these
pacientes con
indicators.
cáncer. Todavía hay muchísimo por hacer.
Cancer
No lo
patients,
veamos
there's a
como
great
un reto,
deal
sino
of
como una
work to do
oportunidad. Y la navegación
still.
de pacientes es algo que
This is
todavía
an
se tiene
opportunity
que
and not a
seguir
challenge, and
trabajando.
we need to work
Se
and
pueden
keep
encontrar
going. We may
soluciones
find
en distintos
solutions in
puntos de la
different
navegación,
points
en
of
distintos puntos de la ruta del
navigation and
paciente.
different
Y
points through the
justamente
patient's
esto es
route.
lo que les quiero
And
venir a hablar.
this is what I want to
Discúlpenme, no me
discuss with
presenté. Mi
you.
nombre
I'm
es
sorry, my name
Alejandra
is
Pérez de
Alejandra Perez.
AstraZeneca.
I
Estoy en
work
el
in
Departamento de
AstraZeneca. I
Gobierno,
am
soy
the
la gerente de
government
políticas
affairs
públicas
team. I am the
y
manager
trabajamos
of
muchísimo
public
con
policies.
distintos
We
actores
work
del
a lot with
ecosistema de salud
different
y de otros
actors
sistemas y de
of
otras
the
industrias
ecosystem of health
para
and
encontrar
other industries
soluciones
and other systems to
innovadoras y por
find
innovación
innovative
no necesariamente hablo de todos
solutions.
los
And
temas
I'm not
tecnológicos o
meaning
inteligencia
necessarily
artificial,
about
sino
AI or
formas distintas y
technological
nuevas de hacer las cosas.
things, but
Por supuesto,
different
ustedes
ways to
conocen
do
estas
things. Of course,
herramientas, yo
you know
solamente
these
quiero
tools. I
traerlas un
only
poco
want
como
to
para dar
bring them
contexto de
to
lo que
give
les
you
voy a presentar a
context on
continuación
what
y
I'm
es
to present.
que en la ruta del paciente,
Is
desde el
that in the
prediagnóstico,
root of the
el
patient,
diagnóstico, el
from
tratamiento, el
pre-diagnosis
seguimiento, el
and the treatment
acompañamiento,
and
hay
accompaniment,
muchos momentos
there
donde la
are many
navegación
moments
tiene una
where
oportunidad y
navigation
está demostrado que
presents an
tiene un
opportunity, and
impacto
it's
positivo y
proof that
muy
it has a
fuerte en los resultados
strong
en salud.
positive impact in the results of health.
Es por esto que
This is
queremos
why
invitarlos,
we want to
aprovechando
invite
este
you,
evento, queremos
making the best
invitarlos
of
al
this
lanzamiento
event.
del reto de
We want to
innovación
invite you to the
abierta
launch of
en navegación para pacientes con cáncer de
open
mama. Este es un reto que
innovation
estamos
challenge for breast
lanzando
cancer
desde
patients. This is a
AstraZeneca,
challenge that we are
que es
launching through
otro
AstraZeneca,
laboratorio con el que trabajamos muchísimo en la
Davichi, which is
innovación
another
desde el
lab
para el cáncer de mama y con el
that we are working
Departamento de
with,
Innovación de la Javeriana.
and the innovation
¿Por qué
department
le
of
llamamos
Javeriana
un reto
University.
de
Why
innovación
do we call
abierto?
this
Pues
an
bueno,
open
innovación, como
innovation
les
challenge?
decía,
Innovation
no
because, as I was
necesariamente
telling you,
hablamos de algo
this doesn't
tecnológico de
mean
inteligencia artificial,
something
hablamos de
technological.
una forma
It
nueva,
means
innovadora
a
de
new
desarrollar algo. Puede
way
ser
to
una
develop
tecnología,
something.
una
It may
inteligencia
be
artificial, puede ser un
an
protocolo,
AI
puede ser
protocol, a call
en fin, hay
center,
muchas formas de innovar. ¿Por
technology.
qué
There are
abierto? Porque
different ways to innovate.
creemos que
Why
no
open?
solo,
Because we believe that
porque
not
creemos que
only
distintos tipos de
that
actores
different
pueden
types of
definir una idea
actors can have
que mejore
an
la
idea that
navegabilidad
may
de las pacientes con
improve
cáncer de mama en
the
Bogotá. ¿Y
navigation
por qué
of
en Bogotá?
breast
Porque
cancer patients in
necesitamos
Bogota. And
tener
why in
algo un poco
Bogota?
más acotado para
Because
poder
we
implementar esta
need to
solución,
have
si bien
something
sabemos que
more
es una
down to earth
necesidad
to
en todo el
implement
país.
our solution. We know
Entonces,
this
el
is a
7 de noviembre
national
también aquí en
need.
la Javeriana, en el auditorio Marino Troncoso, a las 10 de la mañana a 11 de la mañana, vamos a dar el
In
lanzamiento de
these
este reto. Vamos a contar
auditorium, we will
allí
launch
qué
this
estamos,
challenge
qué
10
entendemos nosotros por
a.m.
navegación, qué estamos
Tomorrow, what we
buscando, qué tipo
understand
de
by
soluciones, qué
navigation, what
tipos de
sort
actores
of
quisiéramos
solution,
que
what sort of
participen,
actors we
los
want to be
términos de
involved,
referencia,
the reference terms,
cuál va a ser el jurado, los
who will
tiempos,
be
todo
the
para que
jury,
puedan aplicar. Van
the
van a ser más o
times
menos
for you
2, 3
to apply.
meses
It
de
will be
apertura de
somehow
la
2 or 3
convocatoria para que
months
tengan
for
tiempo
the
de
call
o
for
crear esta
you to
idea,
have
de
time to
postularla, o de pronto
create
es
your
una
idea.
solución que ya existe,
It may
pero
be
pues que
an
tengan
existing
tiempo
solution, but you
de
have
hacer toda la
enough
postulación
time
del reto.
to
Y pues eso era lo que
do
quería
everything and
contarles
apply. And this is what I
en esta
wanted to tell you
mañana. También
in
estamos
this morning.
apoyando
We are
el
also
Congreso,
supporting
entonces
the
pues
Congress.
agradezco a la
So
universidad
I
por haberme
thank
ofrecido el
the university
espacio
for
para que dentro del
offering
Congreso
me and
pudiese
granting me this
anunciar
space
este reto.
for
Nuevamente,
me
7
to
de
make
noviembre, ahí
these
está
announcement.
ahí está el código QR para que se
November
puedan inscribir.
7th, that's the
El
date
evento
for
es
you
presencial,
to sign up.
pero por supuesto va a
It's
tener su
an
página web, luego
in-person
vamos a
event. We
dárselo
have a website.
una parte virtual, un
It will
webinar.
be part
Entonces, pues, si
virtual
nos
with
pueden
a
acompañar,
webinar.
luego pues estén
You can
atentos
attend
a la
there.
parte
You can be
virtual
with
para
us
que puedan venir.
if you want to come
Y bueno, eso es
or
todo y qué
log in
chévere verlos
virtually.
aquí
This
en
was
este
all.
espacio,
Thank
a
you
la
for
orden
being
también.
here.
Y pues
I'm
muchas
at your
gracias y
service.
continúen con
Thanks
la
so
agenda.
much and keep going with your agendas.
Muchísimas gracias, Alejandra. Esta es una
Thanks
oportunidad
so
muy,
much,
muy
Alejandra. This
importante
is a
para
very important
las
opportunity
personas que
for
estamos
the
interesadas en
people
la navegación.
that share an interest in
Después del
navigation.
cafecito seguimos invitando a las
After
personas que
this
están
coffee break, we
degustando
invite
nuestras deliciosas galletas a que
all
nos
of you who
acompañen
are
en la
tasting
sala.
our delicious cookies.
Invitamos, bueno,
We
el
invite
siguiente conversatorio
the
se
next
titula
panel will be
Experiencia de
titled
navegadores clínicos y no clínicos. La profesora
Experience
Sandra
of
Pacheco
Clinical
será
and
la
Non-Clinical
moderadora del
Navigators.
mismo.
Sandra Pacheco will be
Les
the
pedimos a
moderator
todos nuestros
of
conferencistas
this panel. We
que por
beg
favor
our speakers
hagan un excelente uso
to
del
make
tiempo. Tenemos
good
10
use of
minutos
time.
para la
We have
presentación de
10
cada
minutes
uno de
for
ellos
each
para que podamos
presentation,
realizar las preguntas
just
que tiene
that
el grupo.
we can have
Invitamos a
time
la
for the
licenciada
Q&A
Deyanira
session.
Zúñiga.
We
Ella
invite
es fundadora y
Deyanira
presidenta de
Zúñiga,
la, de la
co-founder
Asociación Metamorfosis
of
de Costa Rica.
Metamorphosis Foundation
Bienvenida,
Association in Costa
licenciada.
Rica. Welcome.
Bueno, muy buenos días a todos.
Good morning to
De verdad
everyone.
que agradezco la
In reality,
invitación
I
para poder
do
participar
thank
y
this
poder
invitation
compartir con todos
to be able to
ustedes
share
pues un poquito de lo que
with all of
hemos
you a
venido
little bit of
realizando
what
desde,
we have been
desde nuestro
doing
país,
from
desde la organización
our
Metamorfosis.
organization,
Vamos
Metamorphosis
a empezar
organization.
respetando el tiempo, porque para los que nos gusta y nos
We
apasiona,
will start respecting times.
¿a dónde le doy? Sí, listo, gracias. Como les decía, los que
As I
nos
was
apasiona,
telling
que se
you,
nos va el tiempo volando,
our
¿verdad?
passion,
Y cuando
time
nos damos
flies,
cuenta, pues estamos ahí sobre el tiempo. Pero bueno,
how passionate that we
la
are.
experiencia de
The
navegadores
experience of
clínicos y
the
no clínicos.
clinical and
Quiero
non-clinical
contarles que
navigators, I
cuando
would like
nosotros
to tell you that
iniciamos,
when
¿verdad?
we
Nuestro proceso de
started
navegación,
this
pues
process, the
desconocíamos
navigation
pues el
process, we
término,
didn't know about
para nosotros era
the
solo
term.
navegadores, ¿verdad?
It was only
Navigativos y no
navigators.
clínicos, eso fue un término
Clinical
nuevo.
and non-clinical
Y bueno,
came
el
later.
objetivo
And the
de este
objective of
conversatorio
these
de nosotros es compartir,
discussion is
pues
to
obviamente el
share
impacto de los
impact
navegadores
of
pues en el área
our
oncológica, que
navigators
es el
in this
área en que
oncological
nosotros
area, which
estamos
is the area that
trabajando
we are
directamente
working
allá
on
en mi país.
directly in my
Esos son
country.
mis datos, ¿verdad?
These
Mis
are
calidades.
my credentials.
Bueno, he sacado una certificación en
I
psicología y también
have a
pertenezco a varios
certification in
centros allá de comités
psycho-oncology.
éticos y miembro de
Also, I'm a
juntas directivas de
representative of the
organizaciones y demás.
ethical committee, and I'm a member of different boards.
Bueno, pero lo hemos venido viendo en todo el lapso
We
de
have
las charlas que hemos estado compartiendo, pero ¿qué es un navegador oncológico para
What
nosotros
is
como
an
organización?
oncological
Es
navigator
esa
for us as
persona
an
que
organization? It's
acompaña, que
a
gestiona
person who
procesos,
accompanies,
que va dando la
manages
mano dentro
processes,
de alguno
and
de
goes
los
hand in
sistemas
hand
de salud.
with
Allá tenemos
the health
4 hospitales
systems. We
nacionales y
have
uno de ellos es donde está
4 hospitals, and
Metamorfosis, el
one of
Hospital San Juan de
which
Dios,
is
donde llevamos a cabo
Metamorphosis and
estos
Juan de Dios
procesos.
Hospital, where we are
El
carrying
objetivo,
out
pues
these
también es
processes. The
facilitar
objective
el
is to
camino del
facilitate
paciente, como
the
hemos venido
transit
viendo,
of
desde
the patient
pues, un
from
diagnóstico que hemos estado escuchando
diagnostics.
mucho esa palabra y
We've
les
been
voy a decir
listening a
por
lot
qué,
to this
hasta el
word
tratamiento.
up
Y
until
bueno,
the
puede ser
treatment.
clínico,
It could be
profesional en
clinical.
salud,
Well, it might be
o no
clinical, a
clínico,
health
¿verdad? Como
professional,
somos
and
varios
not
de
clinical
nosotros,
since it's
sobrevivientes y
quite a
voluntarios.
few of us,
Y
survivors
verlos
and
aquí,
volunteers,
por
and I go
ejemplo,
back here
venirse desde
and
otros
from
sistemas de
another
salud,
system of health, and
desde
the
que es el paciente diagnosticado, porque a
patient is
nosotros nos costó
diagnosed
mucho ingresar
because
en
it
el
was
sistema
hard
de
for
salud
us to
en ese
access the
hospital.
health system in that
Tardamos,
hospital. We
les cuento, 2 años para que nos
took
dieran
2
la apertura
years
a
to
poder
get
ingresar por toda la
the
burocracia en
access to
ese
go through
hospital
the bureaucracy.
específicamente.
in that in particular, but what did we do? We came to the rural areas because that's split, because we split the sectors and we started with the breast clinics in the rural areas. So from the moment the person was diagnosed, they would come to us and we would do, I would come to the hospital door, and that's why
They were diagnosed in the first level of health. We
navigadores,
had some other types of navigator, clinical nurses, social workers. We don't have these people yet. The functions would be the medical coordination. We have a very tight relationship with the hospital and the clinic and others. Follow-up and clinical orientation ever since the diagnostics is delivered. The non-clinical navigator, we are survivors, trained volunteers, that we deliver social, emotional support, contention, and psychosocial. We are being called differently. We are guides, orientators, and we are trying to position the name of navigators. Why are we important? Because we need to start thinking why we want to be navigators, why we want to be a company, why do we want to guide people. It's important to reduce times between diagnostics and treatment. We have worked, we have graduated, we know about the systems. We've been working a few years back in the systems. We know that for us as patient, time is of the essence. And when somebody leaves a consultation room and the world is falling down, that's where we are supposed to come through to help them and help them limitate these barriers. We have a 3-kilometer hospital from point to point, and the person who's never been there, imagine how intimidated he or she will be. We diminish therapeutical abandonment and anxiety because they face these feelings. It's very important to harvest the heritage regarding the treatment, that they don't get high and dry. It's important the communication, an assertive communication between the care levels. We have first, second, and third level. They always get to the first level, but we should have an interrelation between the first and the third level, which would be the national hospitals. And in this way is where we can be the bridge. As a matter of fact, the project was called Bridges. My experience as a navigator, and our navigator's experience comes from a cancer diagnostic. I was diagnosed with breast cancer 22 years ago. On that same day, I was told that I was pregnant. And so, as an answer, and my struggle for my life and my child's life, I decided to train myself because we are not eternal. We need to keep training ourselves, being updated in psycho-oncology, in first aid, looking social leadership, in different leaders, in the creation of groups, from the first level of attention, from the defense of the rights and patient empowerment. We do face challenges, the challenge that we faced, and the resistance of the system to us as navigators, that sometimes they see us as competition, and we want to break this idea with non-clinical barriers for them to be trained as nurses, for them to be our partners throughout these resources and learnings, empathy, setting communitary networks from the rural areas, and of course, continuous education. The impact on the community: have better access to information and services, transformation testimonies of communitary staff, reducing abandonment, and more adherence. We need patients that will survive, but that will also have quality of life through these processes. And there's people like us, survivors with more than 5, 10, 20 years, that may have quality of life. And another thing, work reinsertion of them, it's very important for us, strengthening the link between patient and health system.
Claves para fortalecer el
keys
rol.
to
Pues,
strengthen the role, formation in communication, in psycho-oncology, in rights, and here was born the importance to be trained in international navigation, institutional acknowledgement of the role. This is what we're at right now. The four biggest hospitals in Costa Rica are together now because we want to be acknowledged within the institutionality and the social security of Costa Rica, and the articulation between navigators, clinical and non-clinical. This is our next step. We will take this step because we want everyone to be trained, to be well articulated, and emotional supervision, and very important, the self-care of navigators. We want to avoid burnouts. It's very important for us. And as final reflection, a diagnostic shouldn't mean the end, but the beginning of an humane accompaniment that will give hope. Let's keep building hope together. Thank you very much.
Muchas gracias, licenciada Deyanira.
Thanks so much, licensee Deyanira. We invite licensee Rutilia González. She's a teacher of Rafael Andívar University and a registered nurse. And she's a nurse of the San Juan de Dios Hospital in Guatemala.
Buenos días.
Good morning to all. We thank the opportunity given to us by MPI and the University Javierna and licensee Nancy Peña that has always been next to us ever since the year 2019, that when she invited us jointly with a clinical team from the General Hospital San Juan de Dios. Then in that moment, we were just three of us, Dr. Feldman, Dr. Patricia Chacón, and myself. The only nurse that is involved in this, that for me, it's a blessing to have this opportunity, to have the access toward the necessities that our patients have within the hospital areas. I'd like to comment that our story starts in 2019 with the invitation of Nancy Peña. And we've had a very slow evolution. And why do we have such a slow evolution? Because of our health system that doesn't accept the importance that patient navigation has within that system. They don't see the necessities that we have within our hospitals because it's a whole different world. The first and second level of attention that Guatemala has, integrated by more than 1,200 centers, doesn't know what navigation is. In the hospitals, the network of health services, we have 48 hospitals that make part of the health system of Guatemala. And for the oncological patients' attention, we only have 3 or 2 of that level of attention. We have Roosevelt Hospital and San Juan de Dios Hospital. With specialties, we have ICANN for adult patients, and we have UNOP for pediatric patients. So in reality, these are very few hospitals to care for oncological patients. I'll tell you that in our hospital, we have right now 1,260 beds. These beds, we only have 84 available for oncologic patients. See the magnitude of the necessity that we have to care for these patients. We don't have up to date with nurses that have the oncological specialty. Yes, we are well behind regarding this topic. This is why I congratulate the Colombian nursery because they do have that specialty with oncology. And this is a big limitation in the face of the problems that we want to solve, handling the oncological patients. Nursery in Guatemala, we are prepared on a general level. I'm speaking you right now as a teacher. We are pretty much in the same line Javeriana has, but sadly, we don't have the same opportunities to grow. Hence, we have to create these networks and these links amongst nurses, because we are the ones 24/7 right there next to our patients. We need to be able to provide quality in the care. This is a brief outline of our history. In the year 2023, we keep working extra time, overtime, after fulfilling our duties. Dr. Chacón and myself, after completing our duties, we keep working. We navigated patients. And how gratifying is when the team or the group of nurses in general ask, licensee, these patient will be navigated. How good that support feels. You have no idea how that integration with teaching world and the assistance world, that is navigation, identifying ourselves with our patients according to the needs they have within the hospital area. In the year 2025, in 2024, sorry, in the month of September, we delivered, given the multiple functions that we have within the hospital precincts, we handed to social work, we gave them the navigation program. Obviously, with us monitoring it. Dr. Chacón and myself, we were very attentive with this follow-up, but sadly, we didn't have results. We had no indicators, we had no registers. On the contrary, the patient would complain and would say, nurse, doctor, I need your support. Or with the doctor, we would take the calls and listen, we are to do this, let's coordinate this with this and that patient. We received also calls from a physical small group of navigators that, thank God, Nancy Peña promoted the association, Building Lives Association. These are survivors, cancer survivors. And so we had the contact with these people and we tried to support them. We had a group and we tried to support each other. But let me tell you that the biggest barrier that we have is the system itself. They don't deem these as an important topic. Let me also talk to you where we're at right now. In this year, 2025, September last year, that we trained staff from the hospital that were hired, that are not health professionals, they're not nurses, they're not doctors, psychologists, or social workers. We trained staff from ISAO, from patient care, for them to give continuity to our program. But sadly, we had a negative answer. So then in the year 2025, we saw the light a little. There was a change in the authorities, because in 3 different episodes of changes in authority, they wouldn't listen to us. This year, In September of this year,
La doctora
Dr.
ya funge como funciones
is already working
como jefe de departamento de
as
cirugía.
chief of surgery department of the General San Juan de Dios Hospital, and we started once again. We rescued the program,
Y la buena noticia
and the
era
good
de
news
que
is that
le habían dado recurso humano, una psicóloga
we had human resource available, a psychologist and a nurse, to start implementing our program
a manos de
once again
personal médico y de enfermería.
with nurses and doctors. We've navigated 84 patients
por un mes. Que ya
in
trabajando
1 month
con
that
fórmula,
having worked
nos da un
with the formula gives us 67.7, almost 68% of patients
para un departamento
for
de
a
cirugía.
surgery department.
Son 7 departamentos
We have 7 different clinical
que cuenta el
departments
Hospital General San Juan de Dios.
at the San Juan de Dios Hospital.
Por el momento,
For the time
tenemos esa
being,
cobertura
we
de
have
esas
the
134
coverage of
camas
those
estables
134
que corresponden
countable
a 4
beds
servicios de
that correspond to
cirugía.
4
Dos
surgery
servicios de
services,
cirugía
two surgery
y dos
services,
servicios
and
de cirugía de hombres y 2 servicios de
2
cirugía de mujeres.
for male and 2 for female population. We need more.
Necesitamos
We
la cobertura
need
para el lado
the
de
coverage
adultos,
for adults, and we need
para medicina
coverage
interna,
for internal medicine.
497 camas
This makes 497 beds,
y que
and
solo hay
that
destinadas para el
we
paciente
have only
oncológico
destined for
32.
oncological patients 32
De esas
beds.
32
Out of
camas,
these
cuando el
these
paciente
32
llega
beds, when the patient
a
arrives
recibir sus
to
tratamientos,
receive treatment,
tenemos
We have
esa barrera
that barrier
de que colocamos
that
al paciente
we
en la
place the
necesidad
patient according to the need
en los diferentes
in the different services.
exponemos a nuestros
We
pacientes
expose our patients
a adquirir patologías
to
adicionales.
acquire additional pathologies.
Una de las limitantes que
One of the
tenemos
limitations
también es
that we have
la falta de camas
is the
especializadas
lack of
para permanentes
specialized beds for oncological patients.
y otra de las
And
limitantes es
another limitation that we have is the human resources.
necesitamos recursos
We
humanos,
need
enfermería,
human resources, nurses that can play that role of managers, nurse managers, so that they can support us to implement the navigation.
necesitamos
We need oncological nurses
para que nuestro
so that
paciente
our
sea
patient
atendido.
is properly taken care of.
Tenemos
We have,
a la vez
at the same time, this legal framework that was a light, beacon of light in the dark for us. And up to a certain point, it gives us
nos da un banderazo de
support
salida.
and gives us a way out to
Vamos.
say, let's go
Estamos trabajando
in
con
work.
modelo de gestión
We are working with the management model, hospital management model in terms of
que esto
nursing,
para
because
trabajamos
these
lo que
prepares,
hacemos
we work with the nurse staff, we work on our strategic plan
para darle seguimiento
to follow
al
up
programa de navegación.
on the navigation program and implementing it. We need, please, more staff.
Ya nos ofreció por
And
acá la licenciada
that
Peña,
already here,
también
Dr. Naz Peña
de la Sociedad Americana
offered us, and also from the American Cancer Society, we have had support
y esperamos
to be able to manage that. And we hope to have enough time to be able to keep going.
acá pues es el marco legal
Here, this is the legal framework of the recent policies in my country. On March 2024, the Congress of the Republic approved Decree 7/2024, that is the Law of Comprehensive Health Care for Cancer. This law establishes that the government needs to guarantee the prevention, early detection, and timely treatment and palliative care for cancer without any discrimination. It creates the Unit for Comprehensive Health Care of Cancer, the Council Against Cancer, and a social protection program for those affected.
presupuesto inicial al
An
Ministerio de
initial
Salud
budget was allocated to the Ministry of Health with 600 billion, supposedly, but we don't see any of that in the institution.
Quiero compartir algunas estrategias.
I want to share some of the strategies.
Por el tema de tiempo,
Well, for the sake of time, over here, there's one of the barriers. This is one of the strategy to eliminate barriers in oncological patients. The difficulty of access to timely diagnosis. Here, we are thinking about implementing fast reference and counter-reference controls with specialized hospitals. So in the 3 hospitals that provide the services, creating a particular form so that the 48 hospitals in the hospital network can refer their patients to our hospital, so that we can, in order to facilitate the access here in the hospital, the implementation of a single window for cancers, suspicious patients, in order to facilitate and speed up appointments, treatments, diagnosis, a specific color code according to the cancer type to all the patients with confirmed diagnosis.
Nos vamos a quedar acá.
So we're gonna stop here. We have 15 strategies in our plan, our strategic plan, where we work on costs, human resources, financial resources, and we also have staffing. We have as a proposal for the Ministry of Health. That's what we have for them now. Okay, thank you very much.
Muchas gracias, licenciada Rutilia.
Thank you, Dr. Rutilia. Now, so now we invite Dr. Lucía Escobar, coordinator of the navigation program from the Cancer Institute in Mexico, who will be joining us remote. Rutilia González, can you hear us?
Bienvenida.
Welcome.
Muchas gracias. Sí, sí, los escucho.
Thank you very much. Yes, indeed, I can hear you. So you have 10 minutes for your presentation. It's being shared right now. So please let us know if you can see it.
No.
Go ahead. No yet. Okay, yeah. Go next.
Sí, ¿sí ven
Perfect.
mi presentación?
Sí,
¿Sí la
adelante.
pueden ver? Ok.
La puede
Yeah,
colocar.
can you now go into presentation mode, please? Because we are not seeing it. Yeah.
Bueno, pues buenos días. Antes que nada, les agradezco
Okay.
la
Good
invitación.
morning. Thank you very much for the invitation to this Congress. Thank you, Dr. Peña, for this invite. I will talk about the experience of clinical and non-clinical navigators in the Cancer Institute of Mexico. I want to tell you a little bit about my country, that we have a total population of 129 million people with a life expectancy of 75 years, public expenditure on health of 2.8% of the GDP, and out of the pocket 40%. Cancer incidence per year is 200,000, and deaths 90,000 fatalities cancer per year. Unfortunately, when they are diagnosed, 60% of them are in advanced stages. We have a big challenge that the health system is fragmented. There are inequalities for healthcare and a big financial burden on the families. So the patient navigation program provides an excellent opportunity to reduce inequalities and improve the continuum of care. The idea is for patients to have a better quality of life. So I want to tell you a little bit about the institute. It's one of the main institutes.
Es uno de los institutos nacionales de salud.
This National Institute of Health is one of the main institutes within the institute. This is a third-level institute, which is an oncological reference center where the first and second and third level refer patients to that hospital for that healthcare. We see adult patients, especially those who don't have social security. We try to promote comprehensive healthcare, including medicine, nursery, social work, psycho-oncology, palliative care. We have high demand. As a challenge, we have a high demand of service here, and the waiting times are quite long. So which year, well, we are waiting in general. The government is very interested in this program because we are trying to reduce those waiting times for the healthcare. Also, we face a big challenge that is the availability of oncological medicine. I also want to say, since the patients face several barriers, and we as navigators also face them. One of those barriers usually are the financial barriers, and we are talking about the oncological medications, oncological medicine. We have a large opportunity with navigation because the purpose is to institutionalize the clinical and non-clinical navigators so that we are recognized, and why not becoming more professional. So with this international congress that is being carried out right now, I think that is very good because there are now more hospitals and institutions that are interested now in patient navigation. I wanna tell you a little bit about the patient navigation in the ICANN Institute. It was the first institute with a patient navigation program. It was created in 2007 thanks to the support, technical and financial support of the American Cancer Association. When we started, there was just one navigator and all the others were just volunteers. From 2014 to 2014, it was 4 navigators, and in this chart, you can show that we relied a lot on donations. The more donations we had, the larger the number of patients that we could help. And since we had 4 navigators, and over time there was a decrease because due to a lot of factors. One of them, the pandemic. During the pandemic, we actually had to turn around because it was like a personal care, but we have to find a way to be able to respond to the patient. And so this was being able to get to know a little bit more about the social media and all the technology. It was a challenge for the navigators and everything, like for the new patients. Nowadays, we also navigate in a hybrid manner that is, on site and also online. Until now, we have seen 33,389 patients, 40,000 needs. I can say that one patient doesn't face only a single barrier, but it means sometimes much more barriers: financial, psychological, logistical, because only when we are with the patient and we are identifying it, we have to give priority to the barriers that we can address in that moment. The lessons learned by our program is that it has received great support and dissemination from the authorities. It has high visibility nationally and internationally. It was funded via donations. I want to stop here, make a pause, because I want to tell you, as the experience that we have had, is that it is very important that when we get those resources for the patients, we don't have to lose the objective of a navigation, that is supporting the patient and helping the patient in this process of the disease. Why do I say this? Because sometimes patients confuse that, and there is a moment that instead of seeing us as an accompaniment or that we are empowering them, they see us as providers of resources, and then the objective is lost. So I invite you to be careful and how we actually communicate our role to patients. Likewise, the main deliveries that we had was a chemotherapy, advisory, oncological accessories, like for example, wigs in the devices, healing matters, and also accommodation management. We know that most patients that come to INCAN are foreign, and they will take 4-10 more hours in getting to the institute to be able to get that health care. So, and in the back, navigators were not trained. It was not institutionalized, because if it had been institutionalized, the program would be stronger in order to continue, especially to continue with the human resources. As I mentioned in a prior slide, from 4 navigators, there was just 1 now. It has been complicated in responding to all, in managing all the patients. There was no navigation plan because in the INCAN, or they respond to all the types of cancers. So there was not like a particular journey or path for each patient, but mainly we focus on giving donations or aids. However, now as of 2025, the program is evolving, and in order to include the navigation into the official clinical flow, means that now we are strengthening that navigation together with the Nurses Association, which is an important part of this institution. And in the functional units, we are creating this program. So we are defining the inclusion criteria to be able to navigate the patients from the beginning until to the end. Once this program is installed, what we want to do is to expand it to other functional units. And what we are looking for with those models is to respond to the most vulnerable patients. We can have all of them. However, we need to identify the patient with the higher vulnerabilities. The patient navigations in 2024, we are actually working with the multidisciplinary teams such as doctors, social work, nurses, volunteers, which are an important part in patient navigation. To the lack of human resources, we have the navigators that actually, as mentioned in prior presentations, most of them are cancer survivors, and they have a higher empathy with patients because they know the journey that they went through. So now they help them in a better fashion. We also work with psychology, with the mental health service, psychology for patient support. In this year, we had the training thanks to a City Cancer Challenge and a Navigation Patient International, NPI, where we had this cooperation, this intra and extra institutional help by ICANN. We invited the nurses, which was important as mentioned. So this program was strengthened since we are working together, as well as with the psychologists and also administrative staff, that they are actually, they help in managing the kind of managers. Also, like externally, we invited other health institutions, hospitals, so that they can also be familiar with this navigation program and they replicate it in their institutions. In 2024, for the first time, we had this program of put on the vest and help us navigate. Right now, until now, we have 6 volunteers where we have trained, and it's we make the difference between clinical and non-clinical navigators. Usually, the clinical navigators are a guide for patients and accompany them with the service, because sometimes they don't know, they are not familiar with the service where they are referred. They don't know where the chemio is, where the lab is located. Also helping them in with the accommodation. And when they detect a barrier is when they are referred to the patient navigation coordinators. This is our patient navigation structure, that we have different points of navigation. The first one, we have a consultation navigation program from the patient. From the moment the patient comes from the very first time for consultation, a navigator supports them, verifying all the documents so that no document is missing, so that the healthcare is provided on time. After everything has been checked, then the They are referred to the navigator of the functional unit, that is a kind of manager also, that checks what are the appointments so that healthcare and adherence to treatment is as soon as possible. We also have a patient navigation program in radiotherapy. Patients have a lot of questions about the radiotherapy, simulation, secondary effects. And for that, we have a doctor that explains or answers any doubts about radiotherapy. We have a video where this process is explained in detail. Likewise, there is an intra-hospital patient navigation. So here the objective is for the clinical navigator, so the nurse can explain them about the cares that they should have at home. This with the purpose to reduce the number of times that they need to come to the ER. That would be like immediate response to us. And the navigation program we have with this program of work or labor reinsertion, because we know that unfortunately, because patients have to go to the medical appointments and treatment, etc. So they miss or they have a lot of absences at work, and sometimes they lose the job. So we have this program. It has been for 12 years for the benefit of patients who are in treatment, where and we have also have the program Look Good to manage the side effects, the volunteer program also, that is a key part to be able to help patients navigate, and different support programs. Okay, thank you very much for your presentation. We are a little short on time and still we are missing. Okay, yeah, I ended just some pictures and finally the social media. Thank you very much.
Por favor, no se desconecte para el
Please
panel.
stay connected for the panel. So now we invite Elizabeth Paucar, Director of Hope Patients Cancer from the United States. Welcome.
Buenos días a todos.
Good morning to everyone. Thank you very much to NPI team for an amazing, spectacular job, specifically to Nancy Peña for inviting me to this Congress that in reality I am very excited because I had never seen anything like this before. I've been doing this for over 16 years and I feel very, very hopeful. Why? Because I see that navigation is indeed growing up in this Latin American region, something that I would never thought of a few years back. I'm going to tell you what my struggle has been with these Latin American and Caribbean region. I am hopeful that there will be a day where navigation will be present everywhere in our Latin American Caribbean region. Thank you so much, and congratulations to NPI. My name is Elizabeth Paucar Harris. I am CEO and Director of Hope Patient Concierge. We are based in Miami, Florida, United States. And let me tell you a little bit. My presentation will be a little bit different because our focus is different. What's nice about patient navigation is that there are different branches, and depending on our curiosity or how do you say, our ambition, we can walk these different branches. So who are we in Hope? Let me tell you a little bit about who we are. Some 15 years ago, I used to work for a global institution focused on oncology. Latin American hospitals in the United States, we were in 17 states, and there I learned the importance of navigation. In that institution, clinical personnel were the only ones doing navigation. We could see positive results with patients that were navigated. I'm not gonna be tire you with more about navigation, but I realized that we were recruiting oncologists that came from Latin America and also from the Caribbean region. And with these came a follow-up patients from these countries that were following the oncologists. They would study in the United States, but maybe that person came from Costa Rica, from Ecuador, and the Ecuadorians and Costa Rican nationals would contact these professionals. So what we do was to set the international department where we provide navigation for foreign patients. This was different. This was just done in oncology. We grew a lot, and 8 years ago, I saw the necessity not only in oncology but in other pathologies and other specialties, and that's when hope started. Nowadays, we work every single pathology, but we are strong still and strongly focused in oncology. And we were focused mainly in oncology. And so, what we do, we connect local patients. That's another branch of the United States that we navigate pretty much the same way that we are doing now. But I'm focusing in the foreign patient. There are even more barriers for them. Why? Because logistically, most of all, in the United States, if we connect patients and with big hospitals, normally they already have that clinical navigator and they may have a social worker, but that social worker will not be able to focus in the foreigner foreign patient that doesn't know many things, that may have a language barrier, they don't know the culture. There's a great deal to learn. But what happens with that patient that has to go to a private center, which is not a big hospital? Navigation gets lost in this place, and we have a critical role with such patients. Next. I believe that we have differentiated the clinical from non-clinical. Who's the clinical navigator and non-clinical? We are specialized in the non-clinical part, but we work hand in hand with the clinical part. What are the results and benefits? In the end, it's all about the patient's survival. It's the opportune start. What happens with the patient? Let me explain how we work. We get referrals by oncologists, by surgeons, doctors, other patients that may have been working with us, NGOs, embassies. These are the different ways that we receive foreign patients, or through insurance. We may have a multi-level patient, the one that has no insurance but has limited resources. Maybe they have savings, and right now they are facing a serious, grave cancer diagnosed, and they may be coming to the United States to treat themselves. So they may have insurance, but it's a limited or limited, or we have different options. Or maybe the embassy or the government are paying for that patient's treatment to go to the United States because they simply don't have the technology, the expertise, or the professionals. Maybe Miami, it's the nearest hub where they can go and they have the obligation to pay for such treatments, or an NGO where they go through a crowdfunding, and we have alliances with these sort of agreements. We have clinics where we have prices according to different levels, the most economical possible for whatever patient, or a patient that may have a GoFundMe figure. I believe that every patient needs to have a great deal of knowledge of the expenses. We also have the patient that gets through their private jet, they have unlimited economical means. This is another type of client we have. But in the end, whatever client we have, our goal and our objective is to give them quality of life and grant the survival of the patient.
¿Qué pasa con
What
cuando tienen
happens
un
when
navegador a su lado?
they have a
Mucha
navigator next to them?
diferencia. Al paciente que
Everything
viene
happens.
del
The
extranjero
patient that
solito.
comes from
Hemos
abroad
escuchado
by
1000 testimonios
themselves. So
donde
we've listened to 1,000
estaban en hoteles
testimonies where
esperando
they've
semanas a
been
que
waiting for
responsable les
weeks
haga la
in a
llamada.
hotel
En los
to
Estados Unidos
receive a
es muy
call from a
complicado el
hospital. In the
sistema de
United
salud.
States,
Sí
health
tenemos de todo,
system
pero es
is very
complicado para
complicated.
pacientes
We have
que es del
everything, but it's
extranjero.
complicated for
Es
foreign
mucha
patients because
llamada, es
it
que
takes
le
a
bajan
lot of
boletas, que es
bureaucracy,
coordinador,
calls,
es larga
go through
distancia, o sea,
coordinators and
es
long
muy
distance
complejo
calls.
y
This
se
is
frustra
highly
mucho
complex and
y
it's
pierden
very
mucho tiempo,
frustrating, and
¿verdad?
you
Y aquí en el
lose
tránsito
a great
decíamos
deal of
que
time.
tiempo
And
es muy
cancer
importante, que
doesn't
ellos
give you
no
1 minute.
solamente es el
Time is very
inicio de
important
la
because it's
terapia,
not only
también
the
el
beginning
término.
of
Entonces
treatment,
nosotros ayudamos con
it's
toda esa
everything. So
parte
we
de la
help with
logística.
all this logistics.
El apoyo emocional, y vuelvo a
The
la logística, es
emotional
muy
support, and I go
complicado.
back to logistics.
Claro,
This is
tener
very
Escobar a su
complicated.
lado mejora la calidad de vida. O sea, se
Having that
puede
navigator next
recortar
to
una
you,
parte de la
you can
gestión, que es
focus
todo lo
in
administrativo que
not
nosotros
the administrative part,
resolvemos.
which
Para
is the
ellos
part
es
that
más
we
que se
solve
enfoquen
for
en toda la
them.
parte
It's all about
que se
focusing
recuperen, ¿sí? Que se
in
enfoquen
their
en
recovery,
sanación.
that they can focus in
Aquí
their
pongo un poquito de
healing
datos.
process. And I'll give you
Creo que
some
hemos hablado
figures,
mucho
some
sobre
data.
las
We
estadísticas
talked a lot
del
about
paciente que tiene
metrics
navegación. Y
and
aquí
statistics
les
of
muestro un
the
poquito,
navigation
especialmente hay
patient.
muchos
Let me
estudios,
show you a
pero
little bit.
en
There
cáncer
are
de
many
mama, usted ve que
studies
hay
and
un
research. In
porcentaje
breast
muy,
cancer, you
muy
see that
alto,
we have a high
igual al
percentage
inicio y adherencia del
at
tratamiento.
the
Todos
beginning
sabemos que
and
si
throughout
alguien
the
nos está
adherence of the
ayudando a
treatment. If
aceptar un
somebody's helping us
trámite,
to
peor
do
un diagnóstico, o sea,
whatever
hay alguien de la mano que
or
le
a
está ayudando, donde
diagnostic,
se
if there
siente
is someone
cómodo, se
next to us
siente
and that
confiado,
person
que
feels
usted está de su
comfortable
lado,
and they trust you,
no hay razón de
there
por qué
is no
nunca
reason
tratarse.
why you
Lo vemos
shouldn't go
mucho
receive
cuando no hay un
treatment. We see
navegador.
this a lot when there is
Aquí
no
otras
navigator
estadísticas,
available.
reducción de hospitales.
Other
O sea, eso,
stats,
hospitalización, eso es lo más importante para
hospitalization.
nosotros
This is
como
very
empresa,
important
es que ese
for us
cliente
to
no nos lleve
reduce these rates,
a un
that
hospital
the
de
client
emergencia. Porque si
doesn't have
estamos
to go to
manejando
an
los
emergency
riesgos,
hospital,
ojo,
because if
a
we are
veces llegan
handling
súper
that person
tarde en
correctly, they may
su
arrive a little bit
diagnóstico, pero
late
aún
with a
así
late
es tratar
diagnosis,
de
but
eliminar esa
we try to
hospitalización.
eliminate hospitalization.
El objetivo es de
The
forma
objective
rápida,
is
eficiente y
in a
humana.
fast
O sea,
fashion to
nosotros
be
entendemos
humane.
súper bien que cada
We
día que ese
understand that
paciente está fuera de su país,
every day
está
counts,
aislado de su
and
familia,
every
o
day that
saliendo por
they're
una vía
away from their
cirugía,
people and from
y
their
no está
country
trabajando,
counts. They
son
may be
gastos no
away from
solo
family,
de
they may
hotel,
be not
de
working,
alojamiento, de
with
comidas, o sea, de
huge
todo. Entonces, para
expenses to
nosotros
cover.
tenemos que ser
So
súper
we need to
eficientes
be highly
resolviendo.
efficient
Aconsejamos, por
with
ejemplo, venga
the
un
times.
domingo, que ya el lunes
We
sea
advise them
festivo en el
that if
veterinario, pero,
they
o sea, full,
will
que
be
en la
there
mañana se
on
alcance, porque
Sunday,
esa
that
semana
on
vamos a estar
Monday,
tratando de
everything
que
will
ese es el
start
objetivo
running.
de
So
nosotros
that's
cuando
our
tenemos un
objective when
cliente.
we have a client.
Claro, marcar la
Of
diferencia
course,
entre la
we
vida y la
set
muerte.
the difference between
Y
life
no
and death.
paso por ejemplos porque
I'm
de
not going to
parte
give you
de lo
examples
explicado
because
es obvio
I
cuando un
believe that
paciente
it's obvious
comienza
that
con
when a
nosotros a
patient starts
trabajar. Y
working with
normalmente
us,
no comienza desde
they
que
see a
llega,
different,
comienza
and
desde
it
el
doesn't
país donde
start
nos
when
están
they get to
recibiendo.
the United
Nos
States.
comunicamos
It
rápido,
starts before
informes de
when we
acuerdo a
start
cómo
talking to
ustedes
them
han
and they're
recibido los
in their
resultados
countries
de la
of
clínica, los
origin, when we
especialistas
start
lo
giving them
necesitan. Todo
information
es parte
about
administrativa para
specialists,
tratar
about
de que el
centers,
paciente no se
hospitals, all
preocupe
this
de eso,
information
¿sí?
to try to take that burden
Y
from them. And
trabajamos
of
mucho en el
course,
sector
we work a
privado. Es
lot
muy
in the
diferente
private
porque muchos
sector.
de ustedes, o
Unlike
sea, para mí,
many of
saco
you,
mi sombrero
for
y si
me,
he trabajado con
I
instituciones
don't know
públicas,
how you
pueden
manage to
hacer todo
do
lo que
your
pueden
work
hacer,
with
la verdad
public
que
institutions. I
un aplauso para ustedes.
applaud you for that work.
Hablamos todo, también lo de las
We also
citas, los
speak
vuelos, la
about
traducción, eso
appointments,
también, si vienen a Miami,
translation,
nosotros trabajamos
appointments.
no
If you come
solo
to
con Miami,
Miami, we
pero
work
con
not
todos
only in
los
Miami,
Estados
but
Unidos.
also all across the United
Nuestra
States.
fortaleza es
Our
que
main strength
tenemos el
is that we
conocimiento, o
have the
sea, si alguien
knowledge.
tiene un
If somebody
diagnóstico de
has
X,
whatever diagnostic,
especialista o el
what
hospital
are the
mejor para ese
specialists, the
diagnóstico. No
better
todos sea en
hospitals.
Miami, tenemos
It may
muchos
not be in
pacientes que
Miami.
vienen con
We have many
unos
patients that
diagnósticos
come with
rarísimos
very
que no se
strange
escucha casi nunca y
results,
tiene que ir
barely
a
heard of, and we
diagnóstico.
need to find the
Toda
place
esa
where they know
parte es
about
el
that
conocimiento y los
result.
recursos que
It's
hay
all
para ese
about the
paciente,
knowledge
en
and
los
the
que
resources
compartimos
And this is what we share and organize to deliver for our patients. If you come to Miami, we will send a coordinator that speaks your language to accompany the patient. This is very nice. And since we are a company for this specific Congress. We have information. If you have whatever question, there is a cost, but I decide for this Congress, if you may have to face such a thing if we were not charged for this first session. You only have to say that you were present at MPI Congress, or that whomever that is next to me, a relative of whomever attended this Congress, and they will receive special prize. And the human part that our coordinators have with patients, for me, this is the key part: empathy, compassion, and for us as Latinos and Caribbean locals, we are very loving, very giving, very warm, more so than a local person. So we focus a great deal in this, and it sets a difference. I would like to have more companies such as ours, because we have immense needs, and even though we have a huge capacity, there is a great deal of opportunity for those who want to follow this work line. Conclusion: navigation center in the patient transform lives. It's not simply an auxiliary service, rather an integral strategy that optimizes clinical results. This is made possible by hope. Thank you very much.
Muchas gracias, licenciada Elizabeth.
Thank you, licensee Elizabeth. We invite Professor Sandra Pacheco to moderate this panel, and to all those present that may have questions.
Licenciadas, muchísimas gracias por
Thank you so much for sharing your experiences. I believe that each one of you from your context has given us relevant, valuable information on how navigation has been lived in your respective countries. I have a small question for each one of you according to the presentation. To your presentation, I'd like to start with Deyanira, licensee. What motivated you to found Metamorphosis?
Sí, muchas gracias. Bueno,
Yes, thank you so
precisamente
much.
es
Precisely,
esa
it's
necesidad
that
de que se sentía la
necessity
persona,
that,
porque lo vivimos, ¿verdad?
because
Cuando
we
uno sale
lived
con de
it
una
when
consulta,
I left
ese desconsuelo,
the
no saber que teníamos a
consultation,
nadie ahí para
that
apoyarlo. Y
sensation,
estaba
that
yo
feeling
chica,
of
son como
loneliness.
22 años,
We're
¿no?
speaking about
Entonces
something that happened
dijimos,
22
no
years
podemos
ago.
más hacer
I
esto,
don't want
y
anybody else to feel that
tenemos que
way
hacer que sea,
ever. We
tenemos que ver
need
qué
to
podemos hacer,
strive
y
uh, mm,
si
to improve
tenemos
things and
esperanza,
see
y
we have life,
posibilidades,
we have
y
hope, we have
entonces de ahí
possibilities,
nació,
and
armamos un grupo de mujeres
there
de la misma comunidad de donde yo soy,
everything started. We started a group with
pues allá en
women
Coronado,
from my
Costa Rica.
community in
Ahí
Coronado, Costa
decidimos
Rica, and we
organizarnos,
decided
y
to
ahí
organize
nació
ourselves, and
y ese
there
mismo grupo surgió la
everything
metamorfosis
started, and
para crear
also
ese
the
grupo
name
de apoyo que
Metamorphosis,
tantos años
to name
después ha
that
dado
group
tantos
that
frutos y se convirtió
so many
en
years
Asociación
later
Metamorfosis.
has become to the in the association, such a fruitful association.
Y para la licenciada
And for
Rutilia,
licensee
¿cuáles
Rutilia,
han sido
what
pues los
were
mayores desafíos que
your
también, qué
what
estrategias usted
strategies
nos iba a mostrar ahorita
you
las
were
estrategias
about to show us,
que han
the
hecho
strategies that
desde el
you've
hospital para acompañar a
implemented
los
from the hospital
pacientes?
to accompany the patients,
Pero ¿qué
but
estrategias
what
están utilizando
strategies are
ahorita con
being
los recursos
used
que tienen
today with the
para
resources that
acompañar
you have to
a los pacientes
accompany
que están
the
asistiendo
patients
al hospital?
that
¿Qué estrategias
are
utiliza
going
ahorita
to
y
your
que han
hospitals?
sido
What
útiles?
strategies have been useful?
Gracias.
Thank you very much.
Definitivamente creo de
Definitely, I
que es
believe
la
that it's
coordinación con el
a
equipo
coordination with a
multidisciplinario.
multidisciplinary team.
Eso es muy importante
This is
para
very
trabajar en
important
equipo,
for
porque cada quien
teamwork,
con sus roles que
because
desempeña
each one has a role
hace las
and
funciones que
they
cada quien
perform the
compete
duties and tasks
en
that
beneficio hacia el
they have to
paciente.
do, trying
Vi
to help the
muchas
patients.
necesidades
I
de
observed
pacientes
many needs
y soy
of the
testiga
patients.
fiel de todo lo que
I
ellos viven
witness everything that they live
y
and need,
eso es
and
como parte
that
también
is
de
pretty
mi
much a
motivación.
part of my motivation. I identify myself with my profession. I am a nurse. I enjoy my profession. And I believe that these internal motivation, because us as professionals should be internally motivated, and this helps us to walk in a jointly fashion with them despite the workload. Thank you very much, Rutilia. Licensee Rosario, what strategies are you guys using in Mexico for your self-care? Understanding that you were left pretty much alone in the with the navigation program now that you have the accompaniment of volunteers. What are these self-care strategies to take care of your voluntary teams in the face of so many tough
Es
situations?
una gran pregunta
That
porque
is a
realmente
great
a
question
veces
because
se
in
nos
reality,
olvida un poco lo
sometimes
que es
you
lo
don't take care of
emocional,
yourself
¿no? Cada
emotionally.
paciente es una historia
Every patient
y
is a different
en mi
story.
caso quisiéramos
And in
tener
my
una
case,
varita
we would
mágica
like to
para
have
poder
a
ayudar a todos
magic
los pacientes, pero
wand
nunca
to help
tenemos.
everybody, but we don't
Entonces,
have that
pues
magic
tenemos el
wand.
equipo de
So
enfermería,
we have
este,
our
de psicología, que
psychology
nos apoyan a
team,
hacer esa
and
catarsis
they support
en el
us to
momento de
do
cuando tenemos
these
un caso de un
um,
paciente, ¿no?
therapy
Asimismo,
in
también
whatever
tenemos
case. We also
a mi
have
jefa,
my
la doctora
boss,
Maverastegui, que también en su momento
Dr.
le presentamos
Marinastegui,
el
that
caso y nos
we
ayuda
also talked
a
her
resolver
about
esta
this,
barrera
and she
comunicacional
helps
y también
us
así con las
dealing with this
voluntarias que
also, and
tenemos
also
a
with the
nuestro lado.
volunteers that we have working with us. Thank you so much, Licensee Rosario. And finally, Licensee Elizabeth, I had many questions, but I'm just going to make two of them. Your customers, your clients, of what countries they come from, and how do you charge these services? Is it a monthly payment or a payment by objectives? They come from different countries. They come from every single country, pretty much from LATAM, the Caribbean, from China, Canadians, Europeans. My peers come from, my parents are from Ecuador. So we have a great deal of Ecuadorians coming, but even the smallest islands come to the United States, but not just from the United States, because there are patients that don't hold a visa. We even help them with the visa process. Maybe they cannot wait for 3 weeks because uh, it usually takes 3 weeks. If they don't have that much time, we want to strive to be zero wait time. But if they can't wait, we have other options: Panama, Europe, Canada, different places where we can direct the patient to. The other was the payment. We charge them just once. It's different to other companies or other people that are working in this. Maybe just one person that does it, and they charge you thousands and thousands of dollars because they say that they save you money and they deserve this. I'm not here to save the business model. We charge a flat fee of $385 to do everything to accompany the patient, and normally this is done once. It may take 1 hour because maybe the patient only required for something very light. It may take 1 month, 2 weeks, 2 months. So whatever time that I go there, they ask me, how do we charge such low fees? Because we have many different patients. So we can give this price because we want to help everyone. As I was explaining, these are other strategies. Of course, the target client is a very high profile client. I want to help everyone, even if it's a GoFundMe and the embassy. mm, This is why we can give these prices. Okay, thank you very much to four of you. Very diverse experiences, different patients.
with different needs, but also the opportunity to navigate with all of them, and it's very nice. Thank you very much for your participation in this process. Thank you.
Agradecemos a nuestras
We also want to thank our presenters. And
Right now, we invite you to the last conversatory in the morning called
Nos acompaña de manera remota la
we will
doctora
be joined us by Dr. Sara Feldman. Dr. Feldman, can you hear us? Yes. About this importance of champion doctor in the implementation of patient navigation. So please, Dr. Feldman, welcome. So give us the sign to change the slide. And we remind also the speakers that you have 10 minutes for your presentation. And after that, we will go with the conversatory or Q&A session. Thank you. Welcome, doctor.
Can you see my screen?
Sí, señor. Sí,
Yes.
sí la vemos.
Yeah, we can see it. Yeah, perfect.
Okay. Muchas gracias para esta invitación y por las otras oradoras y especialmente a Nancy Peña. Pero yo voy a hablar en inglés, lo siento. I'm going to talk about physician champions in patient navigation. This work is collaborative work that I have done with Nancy Peña over the past 20 years at the Pap smear Evaluation Center colposcopy clinic at the Brigham and Women's Hospital in Boston. As we understand, the goals of patient navigation are known, and it's basically to help underrepresented and underserved patients get the care they need. Nancy and I have been working on this for about 20 years, and we're going to talk a little bit today about what we've learned and how we've learned to work together. As you know, patient navigation was founded in around 1990, and it was initially to remove barriers to timely cancer diagnosis and treatment, and the focus was on low-income and uninsured patients. Our project started in 2004 when, to us, it was a very unknown concept. There was a philanthropic donation at the Dana-Farber Cancer Center in Boston for a patient navigation program in order to increase underserved cancer care, patients who are underserved for cancer care. And Nancy was hired. But we found there weren't sufficient numbers of patients who actually had cervical cancer, which was the focus of the grant, at the Dana-Farber, because we have a good preventive services program in the United States. And so we decided to work primarily in the pre-invasive clinic, in other words, the colposcopy clinic, which was across the street at the Brigham and Women's Hospital. So Nancy and I worked together for these past 20 years. I was the medical director of the clinic, and Nancy was the patient navigator. When we first met, we both were new to this concept. We both agreed that we wanted to improve access and continuity of care, but we really had no idea how to do this. And so we decided to learn together and to collect data so that we could see whether the interventions we were doing were working the way we thought they should. We initially focused on the typical patient, which were patients with low resources, no insurance, transportation or childcare barriers, non-English speakers, and we created a database. Every single piece of information we could think of about patients went into the database. It included demographics, outcomes, social factors, where they lived, what language they spoke, how many children they had, did they have a partner, had they ever had domestic violence, as well as every single PAP, HPV, and biopsy outcome. We initially found that in our colposcopy clinic, about half the patients did not show up to a typical clinic. So just to contextualize, we had our colpo clinics on Mondays, and that was a clinic that was serviced by residents and trainees with oversight by an attending gynecologic oncologist. But we would typically on a Monday book 80 patients. We'd have 3 doctors in the morning, 3 in the afternoon, but only half would show up. And so you could see that, first of all, we were overstaffing for the number of patients that actually came. We couldn't predict who would come. We didn't know what happened to the people who weren't coming, and it was a very inefficient way to provide care. So Nancy's first question is, why don't we find out why they're not coming? So she decided to call each patient who missed an appointment. She asked them why they missed it in an open-ended way so they could give us ideas about things that we hadn't even thought about, including the standard reasons. She explained the clinic purpose, Many patients were confused between the pap smear and the colposcopy, and she rescheduled visits to times that were convenient to patients and aided with transportation and other barriers. She also told the patient she'd meet them at the next appointment, and she collected data on the no-shows. We compiled the information that she collected into a paper that we published in 2015, and we looked at all the patients who'd received her intervention. In other words, all the patients who had failed to show up for appointments during this period, 2006 to 2013. And she compared no-show rates before and after she started these phone calls. So remember, this is only the patients who didn't show up and who didn't cancel. So if they canceled, we didn't call them. These are the people that had an appointment but didn't actually show up for it. And this is individual patients. So this reflects many more calls because some of these patients didn't show up repetitively. So there were over 4,000 patients, individual patients. And after she started making these calls, the no-show rate decreased from 49.7 to 29.5%, and eventually went down to 7% at the most recent evaluation. We did find higher no-show rates among African American, Hispanic, and publicly insured women. And about 45% of those no-shows were considered preventable with navigation and education. But what we learned is we were very surprised because the barriers were not always socioeconomic. Often patients just forgot. They didn't understand what a colposcopy was. And a lot of times their provider had not provided education or information about the abnormal results. So they really didn't understand they had an abnormal result. Furthermore, there were often, depending on the culture of the patient, cultural and partner influences. In some cultures, we found that a desire to have many more babies was a concern. In some cultures, it was a concern about, did this person get HPV and were they cheating on them? Often there were male partners who didn't want the patient to come in. Sometimes the patient was embarrassed. And so those were all issues that we needed to address. So the next thing we did was we did a bunch of things. One was we developed educational materials on PAP, HPV, and colposcopy in both English and Spanish, and eventually in several other languages as well. These were educational materials that could be done on your phone, looked at on your phone, or on your or on the laptop when Nancy was in the clinic with you. They were sort of like flashcards, so they were a little more engaging than a typical written material. And Nancy could show the patient how to resource that or how to access that on her phone, if she had a phone, or on the computer in the hospital, if that was better. We also had our staff, our medical assistants and nurses do pre-appointment reminder calls to all patients. We gave standard communication scripts for staff, which included a question about barriers to care, such as transportation and childcare. We integrated that into our clinic workflow. So when a patient was a new patient, the person who scheduled the new patient appointments asked those questions about barriers right at that minute. And if the patient indicated any barriers, she was referred to Nancy before the first visit. And we found that it dramatically reduced no-show rates and improved satisfaction. Before I get into the role of physician champion, I will just say that the financials also improved tremendously because we staffed the clinic initially with 3 doctors per session, and we're able to move to 2 doctors per session and see almost all the patients. And so instead of booking 80 and seeing, let's say, 40, we started to book more like 35 and see, most of those patients with fewer doctors and with not the need to keep rescheduling people. Every single thing we did, Nancy and I would meet about. So the first thing that we wanted to do was create legitimacy for navigation within the care team, because quite frankly, our medical assistants, which are the people who are in the room with us, do the, basically assist us in every way, schedule the appointments, help process the specimens, help us in the exam rooms, all those sorts of things. We wanted them to see Nancy as a real partner. So we started by having a review of all patients who would be seen in the morning with the nurses, the medical assistants, the doctors, and Nancy. And at that running of the service, we would mention each patient's name, what she was coming for, and we would indicate what she needed at that visit. And that might include things like she needs a colposcopy, she needs a Pap or HPV. But if we'd identified a barrier to care, it would also say she needs a consult with Nancy. All of this, as I said, we put into our database so that we were able to ultimately write multiple papers and speak all over the world actually on this concept. And it's been a phenomenally successful thing. I will say, however, one of the most important things is you have to start with humility as the physician partner, because for sure, I had no idea why a lot of our patients weren't coming, and Nancy was really able to, approach these patients and without intimidation and find out really why did they not want to come. And sometimes they didn't trust the healthcare system. Sometimes, it was pain, and we worked on pain interventions as well. But I had to be able to take feedback sometimes about what wasn't working. And Nancy was a wonderful partner in that. We also assessed with data what we found. And by the end, we found that every new patient got patient navigation, because we sort of made assumptions about patient barriers, and we learned over time that we could not assume what any particular patient's barriers were. We found that this partnership transforms care, and it's my true belief that patient navigation should be a part of all healthcare, and so the physician role is also to advocate for system change. We have published our findings and in multiple places, including our educational interventions, and it's our hope that this is a foundation for equitable patient-centered care. I want to thank our team, obviously, especially Nancy, but this is most of our team. And I'd like to say that navigation isn't just about helping patients find their way. It's about ensuring the system doesn't lose sight of them. And of course, that's not my quote. I'm not actually sure whose quote it is, but I want to thank that person and thank you.
Muchas gracias, doctora Feldman, por su excelente.
Thank you very much,
conferencia.
Dr. Feldman, for your wonderful presentation. So now we invite Dr. Chacón, Chief of Surgery, San Juan de Dios, a member of the Foundation Oncological Pension Navigation in Guatemala.
Le recomendamos a la doctora el
So
uso
now,
del
please,
tiempo.
doctor, remember the time. Yeah.
Bueno, muy buenos días, agradeciendo
Okay, good
nuevamente
morning, and thanks
la
again
invitación a este hermoso
for
país
the invitation to
colombiano
this wonderful country,
por sus
Colombia,
deliciosas arepas.
with its
No sé
delicious
cuántas nos van a
arepa.
subir
I
en
don't
el
know
vuelo,
how many
pero
I can take
lo
with
vamos
me
a
on my
hacer.
flight, but we will.
Pues como todos sabemos,
As you all
la
know,
navegación ahora es
navigation
una
now
realidad en muchos hospitales.
is a
Gracias
reality
a la
in many
visión
hospitals,
de
thanks
un
to the view
doctor,
of one doctor, Dr.
que
Freeman,
identificó esta necesidad en todos sus
who
pacientes, que algo
identified
estaba
this need
faltando
in all
ahí
the
para
patients, that something
tener
was
un enlace más
missing there to
adecuado.
have more appropriate
Él pensó,
connection
necesito
liaison,
una persona
and he
que
thought, I
que
need
me haga
somebody
estas
who
funciones,
can do
¿verdad?
this for
Y
me.
así es como,
And that's
pues,
how,
gracias a esa visión,
thanks to
estamos
that
todos aquí
view,
reunidos
we are all
aprendiendo
here
sobre cómo
gathered, learning
aplicar
on
esa
how to
herramienta tan
apply
importante
that important tool
en nuestros pacientes.
with our
La
patients.
realidad es que todo team de
The
navegación,
reality
todo
is
equipo
that
que se
all
va a
navigation
formar
teams that are going to
para
be
aplicar la navegación
formed to apply
cualquier
or to
tipo de
use
paciente
navigation with any kind of
necesita
patient need
o debe
or should
integrarse un médico,
include a doctor,
ya sea como líder del equipo
whether
o
it's
como un
as a
consultante
team leader or
atrás, ¿verdad?
consultant behind.
Los navegadores necesitan ese
Navigators do need
apoyo
that
y
support
necesitan ese canal
and need
abierto
that open
con
channel
el médico para
with
estar
doctors
comunicándose
so that they
constantemente
communicate
y poder
constantly
transmitir
and be able to
al
transmit
paciente la realidad de su enfermedad, porque
the
lo que
reality
sucede
of
mucho
the
es
disease
que
to the
el
patient,
médico le explica al
because
paciente,
it
pero
happens a lot that the doctor explains to the
muy
patient,
rápido, de una
but it's
forma muy
quite
rápida, porque
fast
tiene mucha
because the doctor has a lot of consultations, a lot of things to do. So doctors forget that they cannot use medical jargon that, of course, patients won't understand. So the patient leaves the consultation, leaves the office. What did the doctor tell you? I don't know. I don't remember. Something about this, yada yada, and they just hear isolated words. So that's where our navigator has to be. That they need to get trained in that medical language, and they need to have the skill to convey that to the patients in the simple language.
Un canal que siempre tiene que estar abierto.
So that's a channel that has to always be open with the doctor.
Lo conocemos como el champion doctor.
This is the one that we know as the champion doctor. That can be the navigation team lead, or as we said, it can be just it can be a consulting doctor. That the main thing is that communication with the navigation team for the medical side. So for the clinical navigation, which is very important. This presentation is based a little bit more on the navigation team. We have heard all the benefits of navigation. So we're going to talk about what main skills are required by a navigator, including doctors that need to get enrolled in this support modality for patients. Effective communication is key. Communicate with the patients in simple, plain language, simple words, without showing stress and without showing no signs of concern or pity, right? With most peace of mind, respecting the cultural differences that we will have, that we see, that we have in our countries, different ethnias, the beliefs that patients have, right? And we can identify, the navigator can actually identify those beliefs and work on them slowly with the aid of psychology, not from the very first time, because it's not, why are you believing that? That isn't true, it does not exist. No, that's not the way to do it, right? So, because the patients would not be open to us, because I will go against their beliefs. The other aspect is the coordination of the healthcare. That's what the navigator will do, coordinate service. That ability to coordinate, to manage with doctors, nurses in the different clinics that the cancer patient has to attend. Because the cancer patient is so special that they don't go just with one doctor. Most of cancer patients, they go to a surgeon, they go to an oncologist, they go to a radiotherapist, and then they go with the support services, that is physical therapy, nutrition, psychology. So it's a great variety of specialties or clinics, and that's where the navigator needs to be attentive, processing or getting the appointments, reminding the patient about that. Case management. This is important because there are patients that need navigation, more regular navigation. They don't need the usual things because they need, for example, appointment management or simple explanation of the disease. But there are some special cases, patients that do need a more profound aid or help of different types of help. So we need to identify from the very beginning the cases that will need more our help, that will need more of our intervention. The psychosocial support that also needs to be a part of navigation. And look at this last thing. I really like to show this. I don't know if this education and advocating for the patient, the navigator becomes like an advocate of the patient's rights. And let's not think about legal meaning of that. No, we will defend or advocate for them in small situations that they can go through day after day. Like in my hospital, it happens a lot in the chemotherapy hospital that the patient might get 10 or 15 minutes late.
And so they don't want to receive the patient. The secretary of the clinic or the person in charge says, no, you are late. Listen, it's my chemo appointment. It's a 3-week appointment. They've been waiting for this appointment for 3 weeks to have this appointment. So there's are many patients that just accept the situation and they just leave, turn around and leave it. And we tell them, no, you should have stayed there because you needed your second chemo or your first. And this is when navigators are helpful. Patients need to be aware of the channel of communication between themselves and navigators. And so navigators can go there and advocate for the patient, even reach in, go straight to the doctor and tell the doctor, hey, listen, we are here. And the doctor will say, okay, let him in or let her in. These seem to be situations not worth it, but they are very important to deal with. The other point is cultural awareness, which it means to understand and respect cultural differences, because we have very palpable cultural differences. We are diverse. And the other thing is the knowledge of the health systems, and this is when it becomes important, the presence of the champion doctor in each navigation team, because they are the ones that know more about the health systems. And all the other navigators, that doesn't mean that they don't have to know about all these. Of course, they need to prepare themselves. They need to learn about these things on how health systems work in their systems and how health system operates within the hospitals, because in our countries we have different ways to act and different routes that the patients should follow in different hospital centers. And so listen to this drawing that I liked a lot because it adds up what navigation is: empower, is concerned, listen, connect to resources, facilitate communication, and even more so, aid the patient to navigate through the physical facilities of big hospitals that can be a complicated process, even to us. I know my hospital, but when I'm invited to another hospital, I'm looking for signs. I stop doctors and I ask people where to get to whatever place I have to go to. And also about indicators in research. How do I know that my program is working? How do I know that I am doing my job in a correct function? So indicators are signs pretty much like traffic signs. They tell you you are to be there in whatever kilometers or miles. We need to look for our indicators. Not maybe some indicators will not be useful for everyone, just for some, but we will be taught in the training session what indicators can be useful for us, and each navigators team can integrate what they can use and what will be helpful and useful for them as a team. So for example, an indicator could be number of people that will make a part of our navigation program. And then we can see what information we need to pull from that indicator. We need to know what are we working at, how much everyone is working, because if I want to assess what my team are doing, if they are working a lot or not so much if they are overloaded. So this is how we are doing it. For these, we need to gather data, the recollection of data. Data gathering is very important in whatever navigation program. It needs to be a continuous documentation process, and you need to keep doing it every several days or weeks or whatever. You can start with a database and with the same tool. If you are scarce with data, or if you are gathering too much information that is generating noise, then you can start to filter your information. This is a continuous process. And the other important part is, why am I collecting all this data? Why? Because I needed to analyze what's going on with all this data and what results am I achieving with my patients. So remember that all this needs to go hand in hand with the objectives that I have marked from my navigation project. And so for projects that are starting, the recommendation is to have simple, clear objectives, maybe 3 or 4 objectives tops, to focus, and with and through experience, you can integrate and add further objectives, and you can plan better your project. So here we have how am I to use this data, handle the patient, improving quality, monitoring the program. If I am doing it the right way, this can be good to monitor program, and it becomes a cycle here. Gather data, analyze, establish conclusions and improvements, analyze data, and I go back, it takes me back to data collection. Thank you very much.
Gracias, doctora Chacón.
Thanks so much, Dr. Chacón, for your excellent presentation. We invite a son of this house, Dr. Mauricio Moreno. He's a specialist in oncological rehabilitation. It's a pleasure to have him here.
Bueno, muy buenas tardes.
Good afternoon. Thanks so much. And of course, when I faced the subject for the first time, I confess that I never thought that I would aim to this dynamic of service. I'm representing here an institution that is the National Cancer Institute, where I coordinate a group, which is a support oncological group, and seeing and listening to all the different speakers throughout the day, and going through and checking everything. I confess I had to study what navigation is, and the National Cancer Institute, we do an exercise of identifying needs, and how from the clinical part, under the figure of the doctor, of a rehabilitator, and the proposal of the World Health Organization, how to address this capacity risk and how I identify the necessities. It's interesting, and within this exercise, how the navigation program strives to deliver patient-centered care to overcome barriers, the systemic barriers, financial barriers, the psychosocial, educational barriers, and how within these needs we also identify aspects that are considered as disparity risks in the care. And under this figure, what is the work of that champion doctor in that leadership exercise, where what we find in literature is that this person should guarantee and sensitize the institution that he pertains, where the importance of that figure is acknowledged and admitted, and that he works also in a sense of proving the necessity of supporting, identifying the involved parts, and how from each part we are delivering the care for the patient, also getting involved in the implementation and the design of the program, and within this design, how we go through the availability from an operative point of view, and how it's not just only the professional or the nurse or the social worker perspective, but other disciplines that make part of this, and how we can guarantee the sustainability and the evaluation of such programs in our institute. Say that we are a small Colombia, where of course we try to deliver an integral attention, but we are somewhat fragmented. And so this navigation program strives to integrate and strengthen the communication from the different disciplines, but we need to guarantee also monitoring throughout the process, because it's useless to point the needs if there is nobody there to take care of it, about the satisfaction and satisfying such needs. Oops, sorry. And speaking a little bit about what has to do with indicators, on one part, what was mentioned before, there are indicators that correspond on how to start the navigation program, and as a strategy within our services, not only for the oncological part, but I believe that I found out that this is applicable for every single pathology. We need to assure our commitment with every single area, from the administrative part to the assistance part, and regarding the indicators of the structure of implementation, how we carry out, how this operative structure is carried out, how we hire our staff, starting from the behavior of the demand, and how we guarantee the training of these personnel, because there are rather important topics from the clinical viewpoint, but also administrative knowledge is important, and this goes hand in hand. And how myself as a professional of the health system, I need to know the model that I pertain to, this health system that I have available or that we have available according to our context and the place that we live in, how I can help that patient and the team to help manage and execute that continuous accompaniment. And within these evaluation that we do from the program, we should guarantee the sustainability, and we should have efficacy and profitable profit indicators, and this contemplates studies from the financial point of view, the tracking of the impact of these, where we require a quantitative evaluation that justifies the investment in these sort of programs. In this sense, of course, there are several aspects that are highly dependent on the human factor, and with this boom that we are undergoing with the technological tools, AIs, etc., on how we can find such resources, because the commitment is not just of the health staff or the personnel that are being trained, it's how we manage to convince the patient, the caregiver, of the importance of these accompaniment that we should have, and also knowing how to employ the resources, where we can make these needs visible, but that such needs will be monitored by somebody when they are registered. And starting from this, I need to confess that I selected the part of the literature that speaks about navigation, patient navigation, where, of course, these sort of needs must be subject to a triage or to a classification process. And there are different levels in this triage process, and there is a universal support where this is like the basic resource provision and the basic needs within the process. There is another level, which is the peer support of the communities, which corresponds to additional assistance that includes accompaniment and interaction with organizations and patients within all the process, and also maybe a more complex level, which is the intensive professional navigation, which corresponds to these accompanying aspects to special complex patients with special needs, those that have difficulty, maybe accessing the care. And in this way, we can plan the interventions for the patients. And I shared another presentation, but I don't know if you received it, which had to do how under this figure we can guarantee these interventions, identification of needs. We can materialize these precision interventions. This would be all. Thank you very much.
Muchas gracias por su compañía en el auditorio. Los invitamos
Thanks so
al
much for being here.
y,
Let's take a lunch break, and for you to be here in time to see the posters that our researchers and our guests from other institutions have outside. Let's be here 10 to 2 p.m. For those remote connections. We will be here 2 p.m. Colombian time.